Okay, all right, so this is our part two of microbiology. So we're going to be continuing, and we're starting with gram-positive rods. Um, Gram-positive rods mean it stains violet on gram stain. It's occurring in angular arrangements transmitted by respiratory droplets. Causes diphtheria. So, Corynebacterium diphtheria causes diphtheria by exotoxin encoded by beta prophage. What is beta prophage, you ask? It is a type of bacteriophage that eats the bacteria. So, diphtheria causes diphtheria. So, Corynebacterium diphtheria causes diphtheria by exotoxin encoded by beta prophage. So, the diphtheria toxin uses exotoxin, and that exotoxin is covered by beta prophage, type of bacteria phage that eats bacteria. Okay. Po- um, Potent exotoxin inhibits protein synthesis by ADP ribosylation of elongation factor 2, leading to possible necrosis in the pharynx, cardiac tissue, and CNS tissue. So, Corynebacterium uses potent exotoxin that inhibits protein synthesis by ADP ribosylation of EF2, leading to possible necrosis in the pharynx, cardiac tissue, and CNS tissue. Symptoms include pseudomembranous pharyngitis, which is a grayish-white membrane, like you see here, like you see right here, and it also causes lymphadenopathy and bull's neck. I'll show you right here. Corynebacteria. See this? This is the pseudomembrane right here, and then the bull neck appearance. It's this. Okay. Let's see. Okay. So, mm, toxic dissemination may cause myocarditis, arrhythmias, neuropathies, and the lab diagnosis based on gram-positive rods with metachromatic blue and red granules and a positive ELEC test for toxin. ELEC test will detect the diphtheria toxin. Okay. So, toxoid vaccine prevents diphtheria. A toxoid vaccine is a vaccine that's made out of exotoxin, and any vaccine made out of exotoxin is called a toxoid vaccine. So this is given to prevent diphtheria. Okay. Now, the main points you have to know about diphtheria is that you see metachromatic granules on Loeffler media. Metachromatic granules are blue and red in appearance, and it is seen on Loeffler media. Remember Loeffler media for diphtheria. Now, black colonies are seen on cysteine tellurate agar. That tells you that the Corynebacteria is growing. These are the main points right here. This is just a mnemonic. So basically, Corynebacteria uses ADP ribosylation. The exotoxin stops protein synthesis in the body by ADP ribosylation of elongation factor 2, leading to necrosis of the pharynx, cardiac tissue, and the CNS tissue. And also, Corynebacterium uses beta prophage, EF2, and the granules. Remember metachromatic granules seen on Loeffler media, blue and red. Okay. Now the treatment is antibiotic therapy with or without diphtheria toxin. Like, so once you have it, you are given antibiotics, and you can either be given antibiotic therapy with or without the diphtheria antitoxin. Okay. So remember, exotoxins released by diphtheria will cause inhibition of protein synthesis, and because of this, the throat cells are going to die and make a pseudomembrane, which is that whitish appearance in the throat, and pseudomembrane um, happens because of the necrosis. Okay, so remember the mechanism of action for this. That's very important. Okay. Protein synthesis is stopped by stopping elongation factor 2 because EF2 is important for protein synthesis. Now we are going, and then positive ELEC test for toxin will tell you that you are positive for diphtheria. ELEC test. Okay. All right. So we are going to move on from diphtheria. Listeria. Okay. So we are moving on to Listeria. This is a bacteria that likes the cold. It is a gram-positive, facultative intracellular rod acquired by ingestion of unpasteurized dairy products and cold deli meats, transplantal transmission by vaginal transmission during birth, grows well at refrigerated temperatures, so it likes the cold, cold enrichment, forms rocket tails by actin polymerization that allow intracellular movement and cell-to-cell spread across the cell membranes, thereby avoiding and the antibody. Characteristic tumbling motility. Remember tumbling motility. Characteristic tumbling motility in broth can cause amnionitis, septicemia, and spontaneous abortion in pregnant women, granulomatosis, infantisepsis, I can't say this word, infantiseptica, meningitis in immunocompromised patients, neonates, and older adults, mild self-limited gastroenteritis in healthy individuals. Okay, treatment is ampicillin. So what we're going to get into is Listeria. It is the third most common cause of meningitis in newborns. Listeria, okay? So, let's see. Pregnant women are much more likely to get Listeria, so pregnant women are advised to avoid eating soft cheese because Listeria likes the cold. Listeria can be found in soft cheese because cheeses do have to be refrigerated, so remember that. Now, the babies, they can get this by transplantal transmission, by vaginal transmission during childbirth. Listeria grows well in the fridge if you have unboiled milk. This makes it easier for Listeria to grow. Okay. See this rocket tails? They like to tumble. Okay, rocket tails. The red is the rocket tails. They form rocket tails by actin polymerization that allow intracellular movement and cell-to-cell spread across the cell membranes, therefore avoiding the antibody. Characteristic tumbling motility. Listeria moves in a zigzag fashion in broth or soup made from deli meats. So they're always moving around. Alright, so antibodies made by plasma cells and antibodies cannot enter cells, so Listeria is safe. So the antibodies are made by plasma cells in our body normally. The antibodies cannot enter the cells, so Listeria is safe. Listeria hides in cells. Okay, it's literally inside the cell, so it evades our body's natural immune system. Okay. Yeah, it can cause amnionitis. Amniotic fluid is filled with Listeria if mom eats infected deli meats and baby gets aborted. Okay, so septicemia and spontaneous abortion in pregnant women, granulomatosis septica. So meningitis, remember meningitis is the major one here. It is the third most common cause of meningitis in newborns. Okay, and meningitis in immunocompromised patients, neonates, and older adults, And Listeria is relatively it's not dangerous in healthy individuals. You can get gastroenteritis, which will go away on its own. Okay, so if a pregnant woman is Listeria positive, in pregnant women, if she's Listeria positive, give ampicillin. You give ampicillin. In pregnant women who is Listeria positive or immunocompromised people, give ampicillin. Listeria causes meningitis in adults over 60, so give vancomycin and ceftriaxone and ampicillin. So that is the treatment in meningitis in people over 60 who have meningitis. Give vancomycin, ceftriaxone, and ampicillin. In pregnant women, just give ampicillin. And the red part of the Listeria is the tail, and the tail is made up of actin, which allows the Listeria to move from cell to cell. Remember actin, okay? The red part of the Listeria is made out of the tail. The tail. The red part of Listeria is the tail, and the tail is made up of actin, which allows Listeria to move from cell to cell. Now, we're going to move on to nocardia. Nocardia and actinomyces. Nocardia is weekly acid fast, right? Remember, we talked about this yesterday. Weekly acid fast. Actinomyces is not acid fast because actinomyces does not have mycolic acid in its cell wall. Okay, so we're gonna go from there. Both are gram-positive and form long branching filaments resembling fungi. Nocardia. Nocardia is catalase positive. So remember, chronic granulomatosis patients have increased risk of infection with catalase positive bacteria. So remember, chronic granulomatosis patients have increased risk of infection with catalase positive bacteria. They are acid fast due to increased mycolic acid in the cell wall. And okay, so nocardia does not form spores. It is found in the soil, but it does not form spores. Nocardia causes pulmonary infections in immunocompromised people. It can mimic TB, but will have a negative PPD test. So nocardia will look like TB, but will have negative PPD test. Cutaneous infections after trauma in immunocompetent people. So nocardia produces skin infections after trauma in healthy people. Can spread to the CNS, central nervous system. You treat nocardia with sulfonamides. TMP-SMX is what's preferred. Treatment is SNAP. So for SNAP, if the patient has nocardia, you give sulfonamides. If the patient has actinomyces, you give penicillin. So up here, this first picture right here, this one is nocardia, and the second picture is actinomyces, which we'll get to in a second. So nocardia uses carbofusion stain to stain acid fast. Okay, and nocardia uses carbofusion stain to stain acid fast. Nocardia likes to spread in neural tissue, so nocardia can cause brain abscesses, as seen here. Brain abscesses. It likes to go to the brain. Okay. Nocardia is urease positive, so nocardia produces ammonia. Okay, that's just some points that are extra. I just said nocardia will be purple and gram stain. It's filamentous, catalase positive. So this is an issue for people with chronic granulomatosis patients who have increased risk of infection with catalase positive bacteria because catalase positive. These patients cannot break down H2O2. Yeah, they can break down H2O2. They cannot break down H2O2, so catalase positive. Because normally what happens in catalase positive is that catalase uses okay, the bacteria comes with catalase. The bacteria will break down H2O2 normally, so that the patient's WBCs cannot come and use the hydrogen peroxide to kill. Can I use the hydrogen peroxide? Can I use the hydrogen peroxide to kill the bacteria? But in chronic granulomatosis patients, they can't do that. So they're at high risk. They're high risk for any catalase positive organism. Okay. We'll get to that when we do chronic granulomatosis disease. Now, actinomyces does not need oxygen to survive. It is not acid fast. It's in the normal oral, reproductive, and GI flora. Causes oral facial abscesses that drain through the sinus tracts. Causes oral facial abscesses that drain through the sinus tracts. It's often associated with dental caries, extraction, and other maxillofacial trauma. Forms yellow sulfur granules. Can also cause pelvic inflammatory disease and IUDs. Okay. So actinomyces can also cause pelvic inflammatory disease in women with IUDs. Okay. So intra IUD intrauterine device. So somebody in a woman with who has PID and she has IUD, they can actinomyces can cause. Oh, never mind. It can cause PID in women with IUDs. Okay, bear with me. I'm also learning. Okay, so let's see. So it causes oral facial abscesses that drain through the sinus tracts, and is cavity made by pus. It's a cavity made by pus. Often associated with dental caries, extraction, other maxillofacial trauma. Forms yellow sulfur granules. Can also cause pelvic inflammatory disease in women with IUDs. So so this actinomyces can also cause pelvic inflammatory disease in women with IUDs. Sulfur granules are pus. Okay. You treat with the penicillin. All right. Okay. Yeah, you give SNAP. Remember that SNAP? I think that is like they like to ask that. So SNAP, AP. Actinomyces, penicillin. Okay. When you see pus coming out of face or oral cavity, think actinomyces. It's a yellowish pus because of sulfur granules. Okay. Now that is that. Yeah. All right. So we did that. We're gonna go into the next page. So I was on the wrong page this entire time, but It's okay. I was reading through my first aid. So, yeah, aerobe. So nocardia, it is an aerobe. It's a weakly acid fast. It's found in the soil. Does not produce spores. It causes pulmonary infections and likes to travel to the brain. It can look like TB, but it'll present with a negative PPD test. It causes skin infections. You treat with sulfonamides, TMP-SMX is drug of choice, and for actinomyces, it's anaerobe. Does not need oxygen to survive. It is not acid fast because it has no mycolic acid in its cell wall. It is a normal. It's in the found in actinomyces is found in the normal oral, reproductive, and GI flora. Causes face abscesses. So if anytime you see some kind of drainage in the face and it's yellow, you see pus coming out, or if you see a woman that presents with pelvic inflammatory disease symptoms and she has IUD, think actinomyces, and the treatment of choice is penicillin. Okay? All right, next. Mycobacteria. Mycobacteria, this is known as walking pneumonia. So this is the... Oh, shit. Sorry. This is mycobacteria. The other one is mycoplasma. Mycoplasma is known as walking pneumonia. Mycobacteria is TB. See, ahead of myself there. Because it's so similar, mycobacteria and mycoplasma. Okay, I was getting mixed up. Okay, so mycobacteria is a gram-positive acid-fast rod. It is pink rods, seen in this picture right here. Yeah, it's seen in mycobacteria. Pink rods. So these are bacilli. Mycobacterium tuberculosis. Mycobacterium tuberculosis are often resistant to multiple drugs. Okay. Now, Mycobacterium avium intracellular is a type of mycobacteria. It causes a disseminated non-TB disease in AIDS patients. Okay, often resistant to multiple drugs. Okay, so Mycobacterium avium intracellular is seen in AIDS patients. Prophylaxis. So the prophylaxis. Prophylaxis with azithromycin when the CD4 count is below 50 cells. When CD4 count drops below 50, you get MAC. When CD4 count drops below 50, you get MAC, which is Mycobacteria avium intracellular, which is super low. So CD4 count of lower than 50 is that's AIDS. Okay, so they're very prone to getting this type of bacteria. Okay, so remember that. Mycobacteria scrophulosum causes cervical lymphadenitis in children. Mycobacterium marinum causes hand infection in aquarium handlers. Okay. So those two are not extremely healed. I think the MAC is that is something you gotta know. Now, TB symptoms include fever, night sweats, weight loss, cough, non-productive or productive, and hemoptysis. Cord factor creates a serpentine cord, which means something that's inside the mycobacteria. So cord factor is something that's inside Mycobacteria TB that causes Mycobacterium TB to make a twisted appearance on more dangerous TB strains. Okay, so more dangerous TB strains have a serpentine cord. Okay, so cord factor creates a serpentine cord appearance on virulent Mycobacteria tuberculosis strains, activates macrophages, promoting granuloma formation, and induces release of TNF alpha. Alright, MNK. So I'm put in. So Mycobacterium activates macrophages, promoting granuloma formation, and induces release of TNF alpha. So the macrophages are the ones that release TNF alpha. So sulfatides are present um, on the surface of tuberculosis, and this inhibits phago, phagolysomal fusion in neutrophils and macrophages. So, to fight TB, macrophages release TNF alpha and IL-12. Sulfatides are surface glycolipids. They inhibit phagolysosomal fusion. All right. Activates the macrophage, promoting granular formation. Promoting granular formation. On virulent Microbacteria tuberculosis strains. Activates macrophages. It activates the macrophages. So Microbacteria activates the macrophages that are in our body, promoting the granuloma formation. So um, macrophages are needed to make granulomas and contain the TB. Okay. Activates macrophages, promoting granuloma formation, and induces the release of TNF alpha. So macrophages release the TNF alpha. Sulfatides or surface glycolipids inhibit phago phagolysosomal fusion. So sulfatides are present on surface of the TB, and this inhibits phagolysosomal fusion in neutrophils and macrophages. So to fight the TB, macrophages release TNF alpha and IL-12. All right, so sulfatides are something that's on top of the TB tuberculosis, and this sulfatides helps the TB because it stops the phagolysosomal fusion in the neutrophils and the macrophages. So, so what the body does to counteract this is that it makes the macrophage the macrophages, which is our body's immune system, releases the TNF alpha and IL-12 to help the body fight TB. Okay, now we're going on to this one. Let's see. Tuberculosis. Okay, so tuberculosis. Here you see Mycobacterium tuberculosis. The hilar nodes, gone complex, gone focus, usually mild and lower lobes. Alright, so this is something you have to know where primary and reactivation occurs. Okay, so reactivation TB. Reactivation TB. Okay, so yeah, reactivation TB happens in the apex of the lung because TB just likes the apex of the lung because that's I guess more oxygenated, and then let's see, primary initial TB infection affects the lower lobes. It's known as gone complex. That affects the lower lobes, and yeah, see this gone focus right here, gone complex. That affects the lower lobes of the in tuberculosis infection, and also it can go to hilar nodes or the gone complex when you initially get infected with TB, and reactivation always happens in the upper lung. Okay, all right. So that is just something you gotta know. Let's see. So here, interferon gamma release assay has fewer false positives from BCG vaccination. Interferon gamma release assay has fewer false positives from BCG vaccination. Alright, so BCG vaccination can give false positives. Interferon gamma release assay is more accurate. PPD positive if there's a current infection or past exposure. There it is PPD negative if no infection, and in sarcoidosis or HIV infection, especially with low CD4 count, you can get a negative PPD test. Okay? So PPD, if you can get positive test if you have a current infection or past exposure. So people who have been previously exposed to TB, you're supposed to get a blood test, yeah, for better accuracy, because you're going to most likely the PPD test is going to come up positive, even if you don't have, even if you don't currently have it. Okay, now the PPD test will be negative if there is no infection. The PPD test will be negative if there is no infection, and in sarcoidosis or HIV infection, especially with a low CD4 count. Okay, so in HIV, no CD4 T cells and no Th1 response, so no macrophages. So macrophages will not come to the PPD site to fight in TB. In SCID, HIV, PPD bump will be flat. So I hope you understood that point. PPD will be negative in if you have no infection, yes, of course, and also in sarcoidosis patients, and also in HIV patients, especially somebody with a low CD4 count, because in HIV there is no CD4 T cells to come to the site of PPD testing, right? What is PPD test? Right, what is PPD test? It's PPD test. So it produces a little bump. This right here is a T cell. This is a T cell response. So in HIV, if there is no T cells, right, or extremely low T cells, so in HIV there is no Th1 response, so no macrophages. So no macrophages will, so macrophages won't come to the PPD site to fight TB infection. And this is also the same for SCID because you don't have T cells or B cells in SCID and HIV, and it will be flat. This bump will not be present in SCID or HIV patients, okay? Or sarcoidosis patients. So here we have caseating granuloma. Okay, we'll go back to Riggs. We have caseating granuloma in TB. We have caseating granuloma with central necrosis and Langerhans giant cell. So this is an example right here. This is secondary tuberculosis, which is a reactivation tuberculosis. Okay. What this is macrophages surrounding TB. This center right here, that's TB. This purple like clutter right here, these are macrophages containing the TB. This is known as a caseating granuloma, right? Okay. Okay, well, and we went through the chart on the side over here, but we said it was Gone complex affects the lower lobes of the lungs, and that is primary infection or hilar nodes also. And then reactivation TB is always going to be in the apex of the lung. Okay, all right. Yeah, that's done. Now localized managers. Interesting. Okay, so we're going to go on to leprosy. Okay. So here, leprosy is also called Hansen disease. Yeah, leprosy is also called Hansen disease. It is caused by Mycobacterium leprae, an acid-fast bacillus that likes cold temperatures, infects the skin and superficial nerves, glove and stocking loss of sensation. Okay, glove and stocking loss. We're gonna look that up. No, I don't know what that is. Glove and stocking sensation. Okay. So I'm assuming that's when you cannot feel your hands and your feet. Interesting. Okay. All right. Glove and stocking sensation. It's a symptom of peripheral neuropathy, which is a common condition that can cause pain, numbness, and tingling in the hands and feet. Okay, so it can cause pain, numbness, or tingling in your hands and feet. And this is a symptom of leprosy. Okay, this is a symptom of leprosy. Also called Hansen disease, caused by Mycobacterium leprae, an acid-fast bacillus that likes cool temperatures and infects the skin and superficial nerves, glove and stocking, loss of sensation, and cannot be grown in vitro. So it can be grown in a test tube. It cannot be grown in a test tube. Leprosy is diagnosed by skin biopsy or tissue PCR. Okay, tissue PCR. Reservoir in the U.S. Armadillos. Where is that? Texas? Armadillos. Oh. Armadillos. Oh my goodness. Armadillos are among the only animals known to carry leprosy. In some studies, have found that armadillos in Texas can test positive for the bacteria that causes leprosy. I knew there was an association. Oh my goodness gracious. That's terrifying. Why is that man touching it? Bruh. Oh. No. Alright, don't touch armadillos. Okay, so let's see where to go. Alright. And cannot be grown in vitro, diagnosed by tissue biopsy or tissue PCR reservoir in the US are armadillos. Okay. I'm gonna make a note of that, okay. Alright. Armadillos. Don't touch armadillo. Don't touch armadillos. Okay. Alright. Loss of sensation in glove stocking. Loss of sensation. Loss of sensation in gloves and stocking area. Leprosy has two forms. Many cases fall temporarily between two extremes. The first one is lepromatous. Presents diffusely over the skin with line-like faces. See this kid over here. And is communicably high bacterial load, characterized by low cell-mediated immunity with a large Th2 response. Lepromatous form can be lethal. Okay, and the other one is a tuberculoid one, and limited to a few hypoaesthetic hairless skin plaques, characterized by high cell-mediated immunity with a large Th1 response and low bacterial load. Okay, low bacterial load. Treatment is dapsone and rifampin for tuberculoid form, clofazimine is added for lepromatous form. Okay, so what this means is there's two forms of leprosy. The one that gives you bumps on your face is much more lethal, um, and is associated with a high bacterial load. The patient typically has a low cell-mediated immunity, so they have no immunity. When they have a large Th2 response, um, that one is very bad. Tuberculoid one is a better one to have. This one has hairless skin plus characterized by high cell-mediated immunity, so it has a high Th1 response, just like in tuberculosis. So remember Th1 um, association, um, high Th1 response in the tuberculoid form, and it has a low bacterial load. In the lepromatous form, it is a Th2 response, not Th1. And for treatment for the lepromatous one is dapsone, rifampin, and clofazimine. And for tuberculoid 1, it is the dapsone and the rifampin. Now I'm going to make a note of that. You should probably make a note too. Alright, so, let's see. TH. Okay, so now we're done with leprosy. So that concludes the all the gram-positive bacteria in clinical microbiology, and we're gonna go on to gram-negative algorithm. Um, yeah, we're gonna go into that in our next video. All right, see you then.